Morning, everybody. Thank you so much for joining us today for an exciting panel discussion planned for all of you. I'm Vibhuti Agrawal, Associate Vice President of Analytics at Innovaccer, and I'll be the moderator for today's session. As you all know, the topic of discussion for today is how would you leverage analytics and AI in improving clinical and financial outcomes within your respective organizations? And for this discussion, we've gathered today an amazing panel, which brings in very unique and diverse perspectives and experiences. So without much further ado, let me quickly introduce our panel members today. So first we have Renee Tollison, who's the Vice President of EVU Analytics and Intelligence at Prisma Health, which is the largest health system in South Carolina. She is a CPA with over 30 years of experience in healthcare. And as part of the Prisma Health, they are managing a network of over 6,000 providers and 500,000 at-risk lives across all payer groups. Renee has also held leadership roles in business intelligence, decision support, and financial systems in her previous organization's Greenville Health System. Welcome, Renee, to our discussion today. Looking forward to having a great discussion. Next, we have Tony Beltran, who's the President and CEO of Pittsburgh Mercy, which is part of Trinity Health now. Pittsburgh Mercy is a faith-based community health and well-being nonprofit organization, which is serving the most vulnerable people and communities, including people with mental illnesses, intellectual disabilities, and addictions, as well as people who are experiencing homelessness, abuse, isolation, and other types of trauma. In his previous roles, Tony has served as the Senior Vice President for Safety Net Transformations at Trinity Health, as well as the Executive Director at Lake County Health Departments and Community Health Center in Chicago, wherein he helped define the comprehensive public health strategy for the city of Chicago. Tony, we are extremely excited and delighted to have you here. Looking forward to your point of view on how data analytics can help truly refine the outcomes, especially for the underserved communities and people with behavioral health problems. And finally, we are joined by Karen Josewick, who's the faculty at College of Population Health, Jefferson University, and is also the president of Benevolence Health, wherein she guides healthcare organizations through their complex transformations. She started her career as a first responder and then grew up to become the nationally recognized executives at various organizations such as Nemours Children's Health and the University of Maryland Medical Systems. She's also been on the board of NACOS, as well as has been an academic advisor and adjunct faculty member for over decades in community colleges and well-known universities. Thank you so much, Karen, for accepting our invite, and excited and glad to have you here today with us also. So before we get into the discussion, let me put forward a couple of logistical items. One is you would see on your Zoom windows a chat option at the bottom. So if you have any questions for our panel members, please do not hesitate to put it on the chat window. Also, during the course of this panel discussion, we'll be having a few audience poll questions. And so please do take a couple minutes to respond to those, because that will help drive the follow-up discussions with our panelists. And so now, without much further ado, let's get into the discussions. So my first question to all three of our panelists is, how are you today leveraging analytics in order to improve outcomes within your current roles? Can you share some of the projects that you've been running within your respective organizations to really promote data-driven decision-making insights in your organizations? So first, Renee, if you would want to answer that.
Sure. We have a couple major ways that we're really using the data to really drive how we focus our priorities on our patients and really structure improvement activities. One of those is around our quality gaps in care. So we do use our provider scorecard that the provider team uses as they're rounding with the providers and the practices. The quality specialist team uses that information to really focus how they can assist and closing the gaps in care. That is one way we do it. And then the HCCs, we are using a combination of the claims and the EMR data to really understand where we need to focus appointments and annual wellness visits to close those HCC gaps, and where we can maybe leverage in meetings as far as with the department chairs on where we need to focus our time. And we really watch that on a weekly basis because of the impact into the next year's premium targets around many of our contracts. So it really becomes something that we have learned to have a lot of education focus. Even if we think the provider knows exactly how they need to capture the data or code it, we're realizing there's a lot of education that just needs to be on the ongoing foundation in our communication with our providers. And the last way we use it that I think is really driving some of that high cost claimants or high risk populations is we use the data to come up with a composite risk score for each patient, whether that's got a financial adherence to medication, closing gaps, urgency factor related to if they have a newly diabetes diagnosis, or if they've shown up in the ED or inpatient. We use 5 different components to come up with what our composite risk score is and within each population, and they care management assignment logic depending on what their needs are, whether that's a pharmacist, behavioral health, complex care management, or just chronic conditions, or what their focus is, so that we can really try to marry the right resource with the right patient load and try to get the engagement and really kind of monitor those that do engage. How do we reach out to the provider and the practice to let them know that they're working with them, as well as what that financial utilization impact is 6 months before they engaged and graduated versus 6 months after. So really trying to hone in on what the ROI on these projects are, and do we need to at least, pivot and try something else if we don't see things moving.
Fantastic. And I think that's the entire point of view around measuring the ROI impact with every single initiative that you're running in is almost becoming more and more important given the current pressures of the finances around. Perfect. Tony, what about you? How are you looking at leverage, or how are you currently leveraging data analytics at Pittsburgh Mercy in order to improve the outcomes for some of the behavioral health patients?
Yeah, thanks, Vibhuti. So as many of you know, Medicaid is actually the largest provider of individuals that have severe and persistent mental illness or substance use disorder. But that means that it varies by state. So in our state, it is very highly regulated. Within all of our programs, we have about 45 different programs. There's lots of regulations. But those regulations are very old and really don't lead to quality of care. If you sign a admission within, 25 hours versus 23, if the target's 24, did that really make that much of a difference? Yeah. So what we did is we started is really gathering data. We're further behind on the social service side, kind of accessing data, but we leveraged Innovaccer to be able to capture all the data that we have. So from our HIE, our county has a lot of data in terms of healthcare management system. Our state has a lot of data. So we've pulled all those together to create one repository. And now every single one of our 45 programs has key performance indicators, both on the financial side and on the quality side. We're going through the next phase of those. So leveraging what is the additional drivers that we need to think through finances. So our chief financial officer is helping us to do that work so that we could have a little bit better sense of why our numbers are showing what they are. And then we're also making sure that every single one of our programs is using evidence-based or evidence-informed measures in addition to the measures that they have, selected. So it is really giving us an overall sense of how we're impacting our individuals. But as a specific example, we have our medical respite program. So those are for individuals who are unstably housed, but being discharged from the hospital and still need follow-up care. So when they come to us, we complete a social determinant of health questionnaire, as well as a daily living activity, which is more on the behavioral health side, really to understand their needs. And we've built within the case management structure so that once we identify needs, we actually create a plan, review that with the individual that's staying at respite, and then within that 30 to 45-day stay, really work on addressing those particular items that have come up in both the SDOH and the quality of life scales that we're using to address that. That has been really helpful for us having impact, where we have a population of people that need a lot of service, but really focusing the impact in a way that will help them as they leave, not only recuperate medically, but be able to have more success going forward. So those are just a couple of ways for Vibhuti that we've been using the system.
Absolutely fantastic. And I think the theme that emerged out of both Renee and your responses, basically segmenting the populations, identifying folks with specific needs, and then marrying that to the case management, care management systems to ensure that those needs get adequately addressed. Karen, what are your thoughts on this? Like, I know you've looked at the you've managed the pediatric population previously. So how did you leverage data analytics there? Was it very similar to how Renee and Tony have described it, or did you use something different also?
Yeah, no, I mean, echoing what Renee and Tony are describing, I think what you're hearing is best practices of what we know and how do you manage populations and leverage the tools that you have. You know, one of the things I would offer is that not every organization has the analytics that we're describing and the tools to manage their populations, and they're continuing to go at risk. And this is a challenge as the organizations are looking to take on more risk, and the CMS is looking for more risk to be taken on by organizations. They need these tools in place. You need the skill sets of, you know, leaders that know how to look at the data, analyze it, and have, you know, experience in data science. And I think that there's gaps across the industry in this space because some organizations are very fortunate, others are not. You know, Vibhuti, the one thing I would offer that I think is really exciting about where analytics has gone in the last 5 years, I think all of us can say that it's changed dramatically. I mean, I've managed populations on Microsoft Excel, and now I've managed, you know, populations, you know, with analytics tools, and there's a huge difference, but we still have work to do, right? There's still so much more promise, and I really am excited about some of the new clinical decision support tools that are coming out and how that's integrating in with analytics. I really like how NLP is going to help provider notes and documentation and how that is going to help streamline workflows. And I think those are just two examples of where the analytics on the back end are going to be even more important. You know, so I would offer those to think about.
Absolutely. No, fantastic. And I think, as we all know, that there's a lot of information sitting in the unstructured data, progress notes, discharge summaries that doesn't even make its own way into those structured fields on EMR. So yes, NLP combined with ambient listening, combined with some of the clinical decision supports, definitely going to be the way forward here. But I think, and Karen, you brought up a great point. Like, there are still challenges that we are talking about here, whether it's the challenges around access to data, access to tools. There are still challenges out there in terms of driving analytics adoption, driving data-driven decision-making across the organizations. So here I've tried to highlight a few of them, but again, would love to hear from our panelists, like, what are some of the challenges that you still see today in driving this adoption of analytics? What has improved over the last few years for you, whereas where the gaps today exist today also? So Tony, let's start with you first on that one, because I know that you've had a journey even in just getting access to all the data and putting it all together. So let's talk through that, because this data is going to become more and more important in future.
Yeah, thanks for Vibhuti. So it has been difficult. I thought this would be simple, getting a lot of this. We knew where the data existed, but we actually knew that we would not be able to do this on our own. Kind of mapping the data from lots of different systems has been difficult. So I mentioned we were getting data that we enter into the state system. We now have a standard way to pull all of that data out. Our county does an incredible job with capturing data, both on the claims side for Medicaid, but also on basic things like jail data, other components. So it's taken us a long time just to get all the data sources into a repository that's available. There doesn't exist, other than the county's data, something similar. What the county is missing in their data is really all the electronic health record data that we also have plugging in here. So it's the first time we can kind of longitudinally see someone. But I would say it's taken us about 2 years to get to this level of maturity in terms of building this, partially because it hadn't really been done before, not only in our county, but really in Pennsylvania. And I don't know others around the country that are doing this kind of on the social service side in the same way. The other thing that we're looking at is how do we think through contract negotiation? How do we move to, alternate payment models and value-based payments? We know the work that we're doing does have cost savings, but how do we address that? The hard part is we cannot use traditional models to look at that. So we can't take what the medical spend is and then say we're going to decrease it. In fact, for our populations, that probably do have a smaller spend. And then once we provide services, comprehensive behavioral health services for their needs, or more comprehensive services and wraparound for those that are living in camps or in our shelters, what we realize is their costs actually go up. Because there is comprehensive care, they're getting consistent medications. The individuals that stay in our residential locations are getting meds every single day consistently. Our med error rate, including admission, is less than 2 a month, and we are caring for thousands of individuals. So the costs go up. So we've been working in terms of this challenge. How do we look at similar populations based on their risk and age-adjusted scores? How do we think through that? And then we're starting to try to understand, can we leverage that into a contract to say those with this intervention that we're providing, here's their cost, and those without, here is their cost potentially. And so while you don't see the savings in the same attribution group, you see the savings in terms of comparison. But we're having to build that from that model within the system from scratch. But hopefully by the end of the year, we'll have our first version of that, which is really exciting.
No, that's awesome. That's awesome. And I know we are partnering on that. So very glad and excited to be part of that journey with you. And it's true, right? Like even when we were discussing internally around some of these risk stratification, patient segmentations, you might not realize the cost savings within the same year. You might even realize it over the course of period. And so as Tony, you're describing it, we need to look at those cohort of patients where the interventions were done versus the cohort of patients where the interventions were not done, not only over a single year or single performance year, but multiple years to look at the total cost of care eventually, over a time window. So yes, that continues. And I don't know if anybody out there in the industry has built out tools or thinking about it in that manner. So great ones. Renee, what have been your challenges with respect to getting access to the data, driving adoptions, driving data-driven decision-making at Prisma Health?
I think one of the biggest things is that data quality and standardization. While we had, our arms around Epic within the system, we had 170 practice locations that were on different EMRs. And so really doing a couple of things with Innovaccer, being able to outsource those HEDIS definitions, maintenance and calculations of the measures is huge, as well as helping with that EMR integration and mapping, understanding that the workflows and all the discrete fields and the way it's happening in those other EMRs is very different. And so each one becomes time mapping through and understanding how do you, maybe they don't understand, they're not wording it the right way, put it in the right field so that you can capture and give them credit for the measure with the payer. So it's working on with their processes and gaining trust and really pushing that data back out to them. I think the follow-up and letting them know where they're at, where you're going, how we're partnering with you is important. And it really frees us up to do some other things because there are so many things on the plate. So having Innovaccer just calculate the measures, help us with the EMR integration and mapping has really been huge.
Yeah, no, absolutely, absolutely. And so the data siloed problem, non-standardization of data quality still continues to be some of the challenges. And I always say it's a garbage in, garbage out problem.
Yes.
You
Yes,
have
and
to
once you
standardize
lose that trust with those physicians, it's hard to get back. So making sure you've done your due diligence and that you're listening to them and fixing things as quickly as you can is a really big deal.
Yeah, yeah, yeah. And that feedback, like you raised an excellent point, that feedback needs to go back to the practices also so that the process is in place to ensure that going forward, the same issues around data qualities or lack of data standardization don't keep coming up.
Right. So you can sustain the things you've improved, because that's been one of our past problems, is not doing that constant follow-up and sharing the data back so that we improved, but we didn't sustain the wins. So that's been a big win that we've been able to focus our time on.
Got it, got it, got it. No, no, that's true. And I think I'll direct one of the audience questions to Karen, since it's related to this topic alone. It's like, how do you encourage clinical staff to really embrace analytics as part of their decision-making process? I know you've been on the side where you work with clinicians, informatics, operations teams. So how do you get them to really, like what I call as data-driven decision-making, adopt that in their day-to-day lives?
Absolutely. Well, you think about embracing analytics, it's really embracing any tool. Analytics is just one tool. And I really kind of go back to the same methodology that you would take with anything that you're trying to help promote change in your organization, right? There are going to be those that are going to be front in line and early adopters and really excited. And there's going to be those that are lagging. And it's critical that you understand why they're lagging. And to Renee and Tony's points, engaging them and communicating with them and being really intentional with how you engage with them. Some of it has to do also with the culture of the organization. I know nobody likes to say the word culture, but the reality is you have to have alignment. And so the alignment starts at the very top with your executive team and, of course, your mission. But it also goes into how you have rolled out the tools and how they are kind of woven into that fabric in an organization. And I think in time and with the right communications and support, you can get clinical staff to embrace analytics. But it takes time and it takes investment. It's not something that you can just put out there and expect that people will immediately change on. And I think we all learned that with early tools that we've implemented over the last 20 years. Look at CPOE, look at clinical decision support tools, look at Barcode Med, all of these EMR tools that we have rolled out for over quite some time. Analytics is another tool. And dare I say, AI is just another tool. It's the same thing, but it's going to require some major change leadership and culture work in an organization.
Absolutely, absolutely. So the key takeaways are that understand, first get continuous feedbacks with the early adopters to ensure that the organization is listening to them and making changes as required to drive adoptions, and then getting alignment across the entire organization. What about, how do you think about also having that transparency, right? Like, so some of the things we've heard again and again is around making sure that whenever you're showing any analytics output, any AI outputs, show transparently what is driving that. Just don't show a black box number effectively.
Yeah.
And so how would you think through that piece, like having that transparent data and insights flowing to them? What are some of the best practices in that area?
Yeah, transparency is critical for people to trust the data, right? And so think about anything that you receive as a consumer, as a clinician, right? You want to know the source. And at the heart, most clinicians are scientists first, right? And science is driven by data, and they want to know the source of the data and where it comes from. And so I think it's critical to have really clear where data dictionaries, data structure that allows them to know this is where the data came from. Here is the methodology or the approach that was used to formulate these calculations. And that's increasingly important for those that might be naysayers or hesitant to adopt, because they want to understand where it's coming from. I can't remember who mentioned provider scorecards, but that is an area where I know from my personal experience, we had lots of dialogue, lots of where did this come from and how did you calculate it and how often is it refreshed and show me where it came from. So I don't know if Renee and Tony, I see you shaking your heads if you have stories about that, but that's a big one. That's a big one.
Yeah, no, and I know Renee talked about it, and I've personally seen those risk models also, well, composite risk scores basically going into the provider scorecard. So, Renee, do you want to touch a little bit upon how you've been able to drive adoption of provider scorecards within your entire provider network?
Yeah, I think Karen really hit it. This was our second round, and this time partnering with Innovaccer's definitions and really rolling out a provider scorecard branded with our network and really engaging them before, after, during, and constantly each month. We really, they love it. And I think them having extreme knowledge of the definition, where it comes from, how it's calculating. And, sometimes they'll find something and they're like, oh, this isn't right. I did this. And sometimes they're right. And then sometimes it's like, well, you did, but it's not noted in this way. And you've got to record it every year or whatever. So I think it's been a good dialogue of, it's not perfect. It never will be, but we're going to partner on this together, because when we see your performance, and sometimes there's funds flow tied to it based on their quality performance. So they have an invested interest to engage with us, and we want to accurately reflect what they're doing. This is their work, just like we'd want our individual information reported that way. So I think just the way you come across is you're an extension of their practice, or what they're doing, to really partner with them and be transparent in every way.
Yeah,
And
no,
be open to being wrong.
That's right too. That's right too. And I think I'm taking away a few key takeaways for me is being their partners. I think it's the partnership is the key motto here, wherein the organizations are basically partnering with providers to make them feel that they are part of a single mission, single vision, all aligned together to help drive outcomes and make everybody successful. So I love that. And I think, yes, it's that open dialogue between organizations, ACOs, and their provider groups. Even if something's wrong, let's work on it together and fix it. That's what's helping drive the adoptions for some of these advanced analytics pieces. Perfect, perfect. So I think that brings me to a pivot little bit towards talking about how does the advanced analytics and AI, we are talking about the new age analytics coming in, generative AI, everybody's used the chat GPTs here. How is that going to change, or how is that going to impact the way healthcare is or operations are being run on a day-to-day basis? But before I direct that question to our panelists, I would like to ask audiences a couple of poll questions. So Innovaccer team, if we can bring up those poll questions, I want to talk to you about where are you in your journey of implementing AI and analytics? And then what are the areas where you believe AI will have the most significant impact here? And the second question is a multiple choice, so you can pick more than one. The first one is a single choice. So please, let's take a couple minutes so that all of you can respond to that. And then we will have the results of these also get displayed so that we can then talk to our panelists around some of the responses that we are getting. Awesome. Do we have the results flowing in? As soon as we have the results flowing in, let's flash that into the screen. Perfect. So I think a lot of what we are hearing from our audience is that actually some of them have implemented it in a few areas, like 30% have implemented in the few areas, whereas another 30% they've not yet implemented it, but are thinking about it. So that's great, you're on the right path. And then there is 23% of the audience members who have implemented and are much advanced in their journey of analytics. And then I think for the second one, it seems like there's Yeah, the ones that are standing out the most is for population health management and clinical decision support systems, and then for predictive outcomes for predictive analytics for patient outcomes, as well as with the introducing more administrative efficiencies throughout the system. So this is wonderful. This is exactly along the lines of what we'd expected. So let me now ask our panelists the question, right? So Renee, how at Prisma Health, would you align with what our audiences talked about, responded with, where they said AI is going to play a major role in driving like predictive analytics, population health analytics, clinical decision support systems, or are you also thinking about it in different angles? And if it is in these same areas, then can you shed more light on more specific projects, more specific initiatives that you are taking at Prisma Health to, again, leverage some of the new age AI tools?
Mm-hmm. That doesn't surprise me, and I feel like we align with that pretty well. I think the bottom section there around the predictive analytics around prediction of a readmission or future inpatient ED. I think those are all things that we are already doing today in several capacities. That is very helpful, at least with our outreach of patients to hopefully prevent and change that trajectory. Some of the things we're doing, and I think, and we'll talk about that in a little bit too, is around compliance, of being really careful before you jump into that AI space, because what that might bring, and we don't know, it's new. But I think some of the key things that I've heard some of the physicians talk about is some of the responses back to the patients, like when they get those emails and they're responding back, the AI is able to kind of formulate maybe a softer, more personal response back than maybe they would have initially done. So some of those things like that has been something I think from probably a patient satisfaction level has been good. And we have a host of things we're evaluating. So I do see, as far as some of that coding space, definitely have lots of things in preliminary trying or deeper dives into what may do there.
Awesome. And so I think I have a follow-up question for Tony here. So Tony, I know we've been in our previous conversations, we've talked about how Pittsburgh Mercy is looking at stratifying the populations, identifying high needs, high impact folks. Talk to us a little bit more about that as you've now gotten the KPIs established for each programs. How are you thinking about building a more robust patient segmentation, risk stratification engine at Pittsburgh Mercy?
Great. So we're actually thinking about it in two ways. One, in terms of direct care. So our medical director for behavioral health, Dr. Stewart, is working with our other medical directors and chief medical officer to determine, as we look at our population of individuals that we serve, what are the key things that we should be looking out for them, right? So if they've had an involuntary admission to a hospital, there's a definite higher risk for death within the next 5 years. So looking at, age attainment, looking at trauma. So the team is really close to kind of defining this tool, as well as changes. If someone's going to the emergency room a lot, if they're suddenly now going to a shelter, but we thought they were housed, those will all trigger up into a scoring mechanism that we have, which will show both prior risk that follows them throughout kind of their life, but also changes in their risk level and trigger to us, hey, this is someone we maybe need to have on our radar. Like, we haven't heard anything negative, but that's probably even a worse thing, right? They're not there. So using this as a way to do that. But it doesn't match all of our populations. Our team that's working on homelessness has other measures that we wouldn't collect. So history of frostbite is really critical for them, so that they can create plans specifically for those individuals that are sleeping out during the winter months. We would never think about that in behavioral health and psychiatry, but we definitely do it, kind of here, making sure that we have information on immunizations, right? Because lots of wounds and other things happen. So are they up to date with some of the other pieces that they need? So that team is really thinking about some of the same items, but also their specific ones that they will be looking at and are developing that are pretty simple. We'll put those into our electronic health record. They started to do that already, tracking those histories so that we'll have a more robust way as that data, kind of is coming forward. I think, it was mentioned earlier, kind of the need to be a little cautious around AI. One of the things we're also hoping is that as a lot of AI is being developed and thinking about our populations, that they're actually looking at the whole scope of population. So we know lots of individuals with severe and persistent mental illness and substance use are on Medicaid and lower kind of social economics. But a lot of times the studies aren't done on those individuals. So as we think about that, how are we making sure that tools that are being developed really cross the gamut of individuals or focus on specialized populations as well when they're thinking about it? Otherwise, we could have some of the other challenges that have happened in physical health where decisions are made on a subset of population of, say, white males, but it doesn't really cross over and gives us different information. So we're hopeful as it continues to develop, there will be a good sense of looking at across the board and not missing the most vulnerable people in development of AI.
Yeah, no, fantastic. And I think it's very interesting that AI is also helping us now inform what are the additional elements that we should be collecting. Like a combination of AI and clinical decisions or clinical knowledge is helping us inform what are the new data elements that we should be collecting ahead from the patient so that there's a better stratification, segmentation models that can be built out. And I think on that point, Tony, just to double click, because our audience has a question around this saying that, are there any standard purpose-built segmentation models that you find, or is this something all that you're building in-house proprietary for your for your organizations? So that's the question that one of the members of audience has asked us.
So we're looking at evidence. We don't have a standard model. So we're doing a couple of things. One, I think there's an earlier question, how do we leverage Trinity Health as a large system? We're very specific because it's mostly hospital-based. So we're, as a non-hospital entity, we are really focused on a different population. But we learn from that team around data. We learn from them on analytics. They are extremely helpful in giving us information and in managed populations. So that's, that definitely has been something that we've been able to do. We are trying to develop these. So we do a lot of literature searches to see if we can pull some of these and create benefits. We're looking at SAMHSA, which has a lot of best practices, as well as kind of National Council addressing homelessness. So we're looking at those, but there's not a model that's necessarily set, especially on alternate payment models. Because again, there is going to be a bell curve. And I say this, the population we take care of, something major is going to happen to them. We just don't know when. It's much harder to predict when someone that has substance use disorder, when they're going to start developing additional complications. Is it this year? Is it next year? Is it 10 years, right? Or an event. But when they do, it costs a lot of money. They're often in the ICU. They have extended stays in relation to that. And so it becomes difficult. We're looking at things like, can we think about prevalence? Can we look at risk stratifications against similar models? So we are building portions of this ourselves. Anyone that's seen anything that's out there, let me know that can make sense, because it is challenging. It's also really, really exciting. But we're also going to have the tough conversation, which is the work we do will save lives. It will improve quality, but it may not save money. And so then we're really going to, our elected officials to say, where do you want to place your money? And maybe the shift is decreased, jail, usage, or decreased other things, right? So can we get dollars from there? But it is difficult, I think, to your question, Vibhuti. We don't have set models. We're kind of building them as we go along, but looking at the evidence of others that have done it and done behavioral health APMs to help inform us.
Absolutely. Makes sense. And so I know both of you, Renee and Tony, touched a little bit upon the importance of having AI governances. So let me direct my next question to Karen. Like, what are some of the guardrails and policies that organizations need to think about as they are looking at implementing some of these AI tools, technologies? What are things that they need to be conscious about?
All right. Well, thank you. I think there's an opportunity to maybe have a whole session just on behavioral health and substance abuse. So I'll flag that because I think Tony's bringing some great insights, and would love to talk more about
Absolutely.
that. So, guardrails, there's a couple of things that I think it was touched on, but I'll call them out kind of specifically. The ethical considerations around use of AI is a big one. And I think we're starting to hear talk about it, but not in a way that I think is going to be as we move forward, it's going to start to advance more. A couple of things that are worth just noting. HHS has restructured, right, their executive team around health IT, and they are looking for a chief AI officer. Right, that says something. When HHS is looking for an executive to be over a specific area around the use of artificial intelligence in the healthcare sector, that's a big deal. So I would flag that for everybody. I think, Tony and Renee both talked about fairness and bias, and the importance to make sure that you have the right structure to look at your models and to make sure that you're looking at bias that could be sitting in populations, and the data that we're using, whether you're using Medicare, Medicare Advantage, Medicaid, commercial, all of the data that we have access to does not represent all of the populations that we are responsible for. And so if you are using AI tools, predictive models, you really need to be very thorough in your analysis of what potential bias that might bring. And it goes back to the transparency conversation that we had earlier around just being transparent with our providers and our care teams, so that as they're making care decisions and recommendations, or you're prioritizing resources, right, as we often have to do, that you're doing it well-informed and understanding any potential bias that could be sitting out there. There's something else that I'll highlight is the data governance and privacy. And data governance and privacy is not anything that is new to our organizations. We've been talking about it for a very long time. But in the context of AI, I think it does highlight and kind of shine some areas where we need to go back and either look at policies and procedures. And so it could be around quality and data integrity, right? It could be around what I just talked about around the models and being able to look at explicit bias, privacy protection. And then one that, to me, I've really been focused on recently is around informed consent. So go back 10, 15 years ago when HIEs were really starting to get steam. And early on, they did not have the level of disclosure, right? If that makes sense. Hospitals were sharing data back and forth with HIEs for payment, treatment, operations, and the disclosure to the consumer and to the patient really came after the fact. And so the question I have is, when does AI fall into that same bucket, right? AI tools are being used. At what point do we update informed consent around the use of these tools? Do we need to? I think there's definitely a policy and compliance discussion to explore. And I'm not an attorney, but I think it's one to certainly to explore. So I think I would raise informed consent as something to talk about in your respective organizations, and would ask Renee or Tony if they have any thoughts around informed consent and what you're seeing in everyday clinical practice.
I think that's really interesting. Within the MSSP or REACH program, the patient, as you have to notify them they're a part of that, they can opt out and not share their data. So I think that is interesting, especially with AI and the concerns just the general consumer has over anything about someone getting their data and using it inappropriately. It does feel like that's probably the road it will go down. I know we have just formed like a team for AI. There's so many things and tools to evaluate that are coming forward that, we want to remove the administrative burden off the physician and make the workflow go easier. But it's, our compliance team and legal team and IT security being, wait a minute, all the different things that we need to look at are really different. And it becomes more of that, not putting patients at risk. And I do think what you said a minute ago, Karen, about the behavioral health, a lot of our populations, if they have behavioral health issues, until you can address those or those social determinants, if they have housing, transportation, or food issues, you're not going to make any movement on any of those chronic conditions until you can help there. And then we're having discussions about, okay, if you are able to get some of that EMR data, the privacy and security of that data, who needs to see it? Even beyond just, just to do your work, what's appropriate to share with who. So lots of discussions that I think with those populations are probably heightened with that AI. But I think a lot of people, I'm just curious, you know, I think we will have to have some policies and procedures around it, especially as we keep expanding and dabbling in it, because I do think most patients would probably be worried about that. And what does that mean in the use of it?
Yeah,
Great
no,
point.
that's very true. That's very true. And in fact, like from our perspective, across the organizations that I've talked to, many of them have formed the AI governance councils. We've been hearing about CMS, HHS, federal governments implementing policies around the use of AI within the healthcare ecosystem. So I think there'll be a lot more guardrails and considerations to be kept in place as we look into the future of implementing these technologies. And that's going to be almost be critical. Like Renee said, Karen said, like patient is at the center of all of this. We need to ensure the patient data is safe, it's secure, and it's not used in any way which is not compliant with the reasons for which it was collected in the first place. And I would like to highlight on that, saying that at Innovaccer, we are committed towards ensuring that any AI models that gets released into production has gone through a rigorous testing of the responsible AI frameworks, wherein we look for biasness, fairness, not just in the outputs of the model, but also in the training data itself. I think Karen brought that point up, is like, when the data is getting collected, do we know all the populations are adequately represented in that? Are we not introducing any unconscious bias in the entire ecosystem? And so if folks in the audience here, they want to learn more about how we have been able to implement that responsible AI framework, how we are helping some of the organizations mature their journey or move more towards mature their journey in the AI space, we do have a few slots available wherein you can talk to either myself or the other experts from Innovaccer. And so if you're interested in that, please respond to this poll question. We only have a limited slots. It's a first come, first serve basis, but we will work with you. We will get on a call, work with you on how, what are the best things, practices as you go in that journey of, or go in your AI journey. So I think with that, let me go to the next piece here, which is more around transitioning a little bit to saying, how do third-party tools play a role in accelerating these analytics implementations? I think all of you talked about the roles that EMR vendors have placed, population health platforms like Innovaccer have placed. So I would love to get few examples, or maybe a couple of examples on how these vendors are helping you navigate your organization through value-based cares or improving healthcare outcomes. Yeah, so Tony, if you want to take that first.
Of course. Yes, so for us, we have a lot of data sources that we're bringing in, and they come from various ways, but they're not all the same. We actually have 2 electronic health records. For example, we have our behavioral health and IDD, where we're capturing some set of data for that. But because we have to be very flexible in terms of changing it, we chose a model that would allow us to do that. However, it doesn't have a physical health data component. So we have a primary care record that we use as well. So even ourselves, they don't communicate with each other. But what we noticed with the third parties, and really why we were looking for another solution, is we have data coming at the state, the county, other levels, data we're just pushing up. Creating standardizations is one of the things that we really needed a lot of help with. When we say patient in one, does that equal patient in another? How do we create a master patient index that's really comprehensive across those systems? It's its own unique skill set to be able to develop and make sure that you're matching, accurately. So that is a place that we definitely have had a lot of help doing that from Innovaccer is what we've used. So we've definitely had a lot of help with all that standardization in the work, something we could not, kind of do ourselves. we had the capacity to do a lot of reporting. We just didn't have the data source for all of that. And also creating one repository where everything, sits has been helpful as well. So that data standardization, we couldn't get to where we are right now without having that. I think that's been one of the biggest things that has helped us. Going forward, it really will help as we start to think about alternate payment models and value-based as well. So again, we needed a module, we have it now, to be able to do that, where we can look at our population of individuals within that. We're doing strange ways of thinking about it. So we're looking at our assertive community treatment teams, for example, as an attributed life based on that. And even though it's a behavioral health intervention, is it helping to save money on the physical health insurance side? We have we're a carve-out state, so our Medicaid plans are separated by behavioral health Medicaid plans and physical health plans. So looking at those examples, as well in some of our residential. So the other place that's really helpful coming forward, and then the next year will be more, is being able to look at contracting for alternate payments.
No, fantastic, fantastic. And I know, Renee, you touched upon earlier about data standardization, HEDIS engines, any other use case that you want to highlight where third-party tools, vendors have helped accelerate the analytics at Prisma Health?
Yeah, I think we have a good many too. And I think it's really the focus is, are they expert tools who do really well that piece that adds value to what we're doing? And they can do it better, and there's a positive ROI. And I think that's something we really are intentional about, evaluating the ongoing ROI of that. And, is it still proving out to be the best thing to stick with? We do, for example, our care managers, just partnering with who is that directory they need to contact to refer that patient that lives near them for food, housing, all those different things that really we need to help them take care of. So several things like that the third party does really well. They keep it updated, and they plug and play with all the tools we have, so that it really is making our life better, and we can spend our time on what we need to. And there is a positive ROI for investing and partnering with that third party.
Absolutely, absolutely. And I think with any of the third-party tools or even vendors, that continuous measure of ROI, value delivered, is extremely important. So to ensure that you're, again, driving everything towards the right outcomes. Perfect. I think let me go to the last one, and this is going to be a rapid fire question from my side, and this is to all three of our panelists. If you could instantly resolve two major challenges, think about, you have a magic wand and you could instantly resolve it, what would those be for each one of you? So Karen, do you want to go first?
Boy, it's a big question. So I think first and foremost, access is probably the biggest thing. We're struggling with access across health systems, community networks, and otherwise. And so access is something that we've got to crack as a healthcare delivery system across our country. It's a big deal. And then the other area would be truly interoperable data. I know there's a lot of movement in Washington to try and do that, but the reality is data is not moving at the speed that we need it to move. And as a consumer, seeing the way that data can move in other segments and other markets, and then I look at the healthcare space, we are so behind. And for some good reasons around privacy and security, as we talked about, for other reasons, just we are not moving at the pace that we really should be and need to be in order to get the investments that we've made in tech to have a return. So those would be the two.
Absolutely. Makes sense. And I think interoperability is the big piece. We've talked about data standardization being a challenge. Interoperable data is one way to solve for that. So absolutely. Tony, what about you? If you could resolve two major challenges, what would those be?
Yeah, so I like the word instantly in the question, because I think we're going to get there, but timing wise. So first, a way to really think about our specialized populations and how do we create these alternate payment models? Like, how do we create the value? So if we had that built in now, I could start negotiating those contracts, really demonstrate value. So if we could, that would be one. Second, getting to full adoption on for all of our users. As we develop the tools that we have available and we start to do more and more that's at the front line and directly impacting, we'll get to adoption related. But if we could get to full adoption right now, then I feel the impact on the people that we serve on a daily basis would happen at a much better level. We could do measurement-based care much faster. So the instant part is what I like. We'll get there, but I have to remind myself to be patient.
Absolutely, absolutely. So how do you demonstrate value for the work that is happening, and especially in some of these specialized settings? And then the other piece is driving adoptions across the users, provider groups. I think we've talked about it multiple times in today's webinar. Renee, what are your thoughts on this? What would you like to solve instantly?
Instantly. I love that word instantly too, because we don't feel that often in healthcare. I will say, I think my two would be focusing on ways to make the workload of the physician lighter.
Yeah.
With with what's coming with less physicians and the amount of after hours working, I think if there was a way for a AI scribe to scribe everything that goes on in the room, not just that physician conversation, and able to discreetly summarize. And the other thing would be is how does it use the data in the chart to use AI to prompt and get that visit ready of what you need to cover? What are those gaps in care and HCC, chronic condition type things, rather than someone else having to go in and get the chart ready.
Oh, yes, yes, yes. And maybe I'll add real time to that, basically.
Real time. Absolutely. Real time's a given.
So I'll add that real time word also there. So reducing the workload of physicians or everybody in the care team networks. And then how do we get those insights in real time at the point of care without having a third person intervene or get them manually readied? Perfect, perfect. Love these, love these. I think that's largely it from our end. I know there are a few questions coming in, and I know we only have 4 minutes to go. So I'll just take one question, and I'll ask this to Renee, because I know, Prisma, you have multiple vendors. So the question that has come from audience is, how do you manage having multiple vendors to take care of different aspects of value-based care?
That's a good question. And I think it's making sure the leaders of those respective areas are communicating and clearly have the purpose of each of those to make sure we're keeping that communication open and making sure we have a distinct purpose and a rollout plan that complements each other, and that we are really tracking things and having the systems to track the contracts and making sure the IT team, all the clinical, the IT, everyone that's representing those areas are aware and working together and no silos, I think is the key.
Awesome, awesome. So again, collaborations, keeping a track. And I think, again, we've talked about ROI a few times, so ensuring you're continuously measuring the ROIs. Perfect, perfect. Awesome. So I think with that, I would like to really thank our esteemed panelists here. Thank you so much. Had a lovely discussion, very insightful. So thank you so much for participating today. And also thank you to all our audience members. We have a feedback form that has come up, so please do respond to these feedbacks. It will help us improve the webinars going forward. Also, you'll see there's a QR code on the screen. So please do not hesitate to scan that QR code. That will help you, again, book a demo with us at Innovaccer so that you know what we are working on. But this is perfect. This is a great session. Once again, thank you to all our panelists. Thank you, Renee. Thank you, Tony. Thank you, Karen, so much. And again, to our audiences, thank you so much. Loved all the questions that were coming up. Really like the engagements. And as well as if the question has not been answered, we will get back to you with the responses over the email. So thank you so much again. And have a good day forward.